35-year-old obese female with Roux-en-Y gastric bypass anatomy presented with acute quadriplegia secondary to a motor vehicle accident. Due to prolonged hospitalization with oropharyngeal dysphagia, percutaneous enteral feeding access was requested. PEG tube was selected due to her surgically altered anatomy, and the gastric pouch had an intrathoracic location, meaning it was not amenable to PEG tube placement. During the PEG procedure, conventional methods for identifying the jejunal puncture point failed due to her central adiposity, meaning we were unable to obtain transillumination or achieve one-to-one abdominal palpation to find the puncture point. Therefore, magnetic balloon technology was used to obtain a jejunal access. Magnetic balloon technology is FDA approved for assistance in difficult colonoscopy, specifically for colonic loop reduction. The way it works is a ferromagnetic balloon catheter is passed out of the working channel of the scope. An external magnet is placed on the patient's abdomen, and the magnet is attracted to the ferromagnetic balloon, allowing the endoscopist to reduce the scope against a fixed magnetic point. A mobile cart houses the permanent magnet handpiece, which is being taken over to the table here. This jar contains 29 grams of carbonyl iron microspheres in powder form. A spike is inserted into the jar so that the carbonyl iron powder microspheres can be mixed with the solvent. The solution being injected here contains sodium chloride, trisodium citrate, and water. The solvent and the iron powder are mixed together, forming the ferromagnetic solution, which is now being suctioned back into the syringe. The balloon catheter lumen is now primed with the ferromagnetic solution, expelling all residual air bubbles. The catheter is now primed for use. Magnetic balloon technology has been shown to have a magnetic attraction range of up to 9 centimeters, or less depending on intervening tissue densities. Magnetic balloon technology should not be used with patients or staff who have implanted ferromagnetic medical devices such as defibrillator, cochlear implants, neurostimulators, etc. Patients and staff with foreign bodies made of ferromagnetic materials should also avoid the device, as well as patients with an iron allergy. The ferromagnetic balloon contains 29 grams of carbonyl iron microspheres. If unintentional balloon rupture occurs during PEG, say during passage of the needle trocar through the jejunal wall, and spillage of the ferromagnetic fluid occurs, absorption is improbable or negligible, and that's because iron requires gastric acid for solubilization and absorption. Here's an example of inadvertent balloon rupture due to passage of a T-fastener during jejunopexy during the PEG. If balloon rupture occurs and ferromagnetic fluid spills into the jejunum, current practice is to avoid suctioning the fluid through the endoscope, as there is limited data regarding the risk of endoscope damage of suctioning carbonyl iron. Jejunopexy using T-fasteners is performed as an adjunct maneuver during PEG. This is so transabdominal access is not lost to peristalsis during the procedure. T-fasteners remain in place until at least 2 weeks post-op to reduce the risk of dehiscence in the event of inadvertent tube dislodgement. Jejunopexy using T-fasteners is performed by the GI providers, and this device can be removed in clinic using a pair of suture scissors. For this case of magnetic balloon-assisted PEG, the patient was placed in supine position, no fluoroscopy was required, and a colonoscope was introduced through the mouth and advanced to the proximal jejunal roux limb. Sterile technique was used for the PEG procedure. Here the balloon catheter is being passed into the jejunal roux limb, and the balloon catheter is inflated with the ferromagnetic fluid. The external magnet is lowered onto the patient's abdominal wall and screwed clockwise to lower the permanent magnet towards the ferromagnetic balloon. Here you can see the magnetic balloon being attracted to the external magnet. The zenith sign indicates that the magnetic balloon is positioned perfectly below the external magnet, as the iron powder forms lines along the magnetic field. Jejunopexy is now performed using T-fasteners to secure the jejunal lumen to the abdominal wall for the remainder of the PEJ procedure. The T-fasteners are made of stainless steel and exhibit no magnetic properties. After jejunopexy, the remainder of the PEJ procedure was performed using the traditional pull-type method first described by Scheich et al. In 1987. Now that jejunal access has been obtained with the trocar needle, the external magnet is removed from the abdominal wall. The magnetic balloon catheter is deflated of its ferromagnetic solution, and the catheter is extracted through the working channel of the colonoscope. It is currently unknown if magnetic balloon technology reduces the risk of colonic or other organ interposition during PEJ placement. We recommend continued use of standard safety techniques during the PEJ procedure to avoid the risk of organ interposition. Magnetic balloon-assisted PEJ should be considered when standard techniques for jejunal puncture point localization fail. It can also be used as an alternative to fluoroscopy-guided PEJ placement. Surgical jejunostomy should be used when either magnetic balloon PEJ or fluoroscopy-guided PEJ are both unsuccessful in identifying a jejunal puncture point. Surgical jejunostomy can also be used in cases of luminal obstruction, which prevents passage of the endoscope into the jejunum. Historically, PEJ technical success has been relatively low due to challenges in localizing a jejunal puncture point. In this case, standard techniques for jejunal puncture point localization also failed due to central adiposity. Magnetic balloon technology magnetically attracted and anchored jejunum to the abdominal wall, thereby allowing sustained transabdominal jejunal access.